Good morning, everybody. I would like to thank Emirates Society of Internal Medicine for inviting me as both moderator and also a speaker at the same time. So what I'm going to talk about is the approach of abnormal liver test and drug-induced liver injury. So you cannot speak about drug-induced liver injury without talking about the pathway to diagnose a drug-induced liver injury. So our objective is to apply the concept of hepatocellular and cholestatic liver disease to interpretation of abnormal liver tests and provide differential diagnosis of acute and chronic liver disease when the usual tests are negative. And we need to utilize and interpret non-invasive tests of hepatic fibrosis, recognize the clinical pattern of most common causes of drug-induced liver disease. So liver enzymes, the new normal. So what you are seeing in your hospital, in your lab, the reference range of ALT/AST is not true. So this is the ACG guidelines suggest the normal value, which should be for women less than 25 and for men less than 33. So how you can interpret and evaluate patient with acute hepatitis. So you can see here the normal range of ALT in these patients. You can see in acute hepatitis due to virus and drug, other than acetaminophen, the range of ALT usually or the 500 to 2000. In chronic viral hepatitis, it's ranged between 40 to 200. In non-alcoholic fatty liver disease, 40 to 150. Alcoholic 40 to 150. You can notice that the AST over the ALT ratio is more than 2 to 1. And in autoimmune hepatitis, ranging between 200 and 1,000. For viral hepatitis and NASH, AST more than ALT often means cirrhosis. You can see here the pattern of ALT/AST with the time in different diagnoses. You can see here the transient biliary obstruction within 2 days it peak and drop, while in hepatic ischemia it's the same time, within days it's peak and drop. Acetaminophen level, it peaks and takes a time, while viral and drug-induced hepatitis varies. So what about hepatitis to a non-hepatitis virus? You can know Epstein-Barr virus, cytomegalovirus, herpes virus, all of them, they can cause hepatitis. So acute hepatitis, when ALT usually more than 500, you can see the different diagnoses, the disease, the clinical clues, and how you diagnose these patients. So drug, you have to, it's compatible with med and timing, and usually the diagnosis is clinical. Viral hepatitis, exposure history, and a positive serology. Alcoholic hepatitis, the patient give you a history of ethanol intake and the pattern of ALT/AST. And also the diagnosis is mainly clinical. Ischemic hepatitis, drop in blood pressure, ALT more than 5,000, marked increase in LDH, and the diagnosis here is clinical. Autoimmune hepatitis, you've ruled out other causes and you have a positive autoimmune serology. Causes of acute severe liver injury, and this is multi-center study of hospitalized patient. They found AST or ALT more than 1,000, 43% because of ischemia, 12% because of pancreatic biliary causes, 11% DILI. When ALT more than 5,000, main cause is acetaminophen, and the other is ischemia. When AST more than 5,000, also it's the opposite, where most of it is ischemia and less is acetaminophen. Etiology of acute hepatitis when the usual tests are negative. So you've done all the tests, you're not sure what's going on. So what you should look for? You should look for drug or toxin-induced liver injury, autoimmune hepatitis, hepatitis E, unusual infection like CMV, EBV adenovirus, Q fever, intermittent or partial biliary obstruction, malignancy. If patient not improving or no clear etiology identified, biopsy in this case is reasonable. So acute hepatitis, clue to diagnose them. So if the patient give you a history of animal exposure, travel, drug use, rash, weight loss, and high LDH, and you can see in front of it what's the clue, what you are suspecting, and what's going to be the diagnosis most likely. So chronic hepatitis, when ALT, in ALT ranging 50 to 150, disease, you can see the disease, clinical clues, and the diagnosis. In non-alcoholic fatty liver, you will find the patient has obesity, diabetes, hyperlipidemia, and mainly you're going to diagnose it clinical imaging and possible liver biopsy. Hepatitis C, risk factor of blood, and a positive serology. Hepatitis B, risk factor and serology also. Alcoholic, again, ethanol intake and clinical. So when you see elevation in alkaline phosphatase, what does it mean? So, if you see a primary biliary cholangitis in a middle-aged female, order AMA. Disease, primary sclerosing cholangitis, usually you're going to find a patient who has a diagnosis or going to be diagnosed with ulcerative colitis, and this is diagnosed by MRCP or ERCP. Biliary obstruction, you're going to find the patient has a jaundice, pain, and this is imaging diagnosis also. Drug-induced compatible agents, timing, and this is mainly going to be clinical. Inflammatory associated, the patient has sepsis, inflammatory disorder, and you're going to find some clue in the blood tests. Infiltrative disease, malignancy, sarcoid, amyloid, and this is going to be diagnosed by imaging and biopsy. So what do we have as non-invasive marker of liver fibrosis? You're going to find an indirect test, AST and ALT ratio, APRI score, fibro test, and FIB4. So there is a direct markers like FibroSpect2, European Liver Fibrosis Panel, and there is also a radiological test like FibroScan and shear wave elastography, and also an MRI elastography. So when you do elastography assessment, you should think about what can increase liver stiffness. These conditions might increase liver stiffness like fibrosis, acute inflammation, hepatic congestion, and you can see the rest of the list. So when there is a liver injury, this is the roadmap that most of patients go through. And mainly this is a part of diagnosis exclusion. So the patient has a liver injury, you do all the blood workup, imaging, take a history about alcohol. When all of these negatives, check for any other autoimmune disease, order the autoimmune workup, and all negative, you're going to evaluate for metabolic and genetics. And in the end, when all of them are negative, you might suspect drug-induced hepatotoxicity. So drug-induced liver injury, general concept, most daily occurs within several months of starting the drug, more likely with dose more than 50 milligram, and lipophilic drugs require hepatic metabolism. Almost any drug can do almost anything, but most drugs have a signature toxicity. Example, augmentin causing cholestasis. So in drug-induced liver injury, biochemical patterns of injury, you have to look for R, which is ALT divided by ALP. In hepatocellular pattern, the R is more than 5, more likely to be severe and cause acute liver failure. There is a Hay rules or Hay law. Patient with DILI with bilirubin more than 2 and ALT more than 3 times the upper normal have a 10% mortality even if the offending drug is discontinued. Acute liver failure definition include hepatic encephalopathy due to DILI carries 80% mortality without transplantation. Cholestatic picture when the R is less than 2, more likely to be prolonged and even chronic. Outcome of drug-induced liver injury. This is a study which done at 899 cases of DILI identified. Pattern of liver injury, 45% had hepatocellular pattern, 23% has cholestatic pattern, and 23% has mixed. 70% of patient has jaundice. Causes has been identified different. Herbal dietary supplements in 16%. Augmentin had 10%, INH of 5.2. And you can see here the rest of medications which cause different percentage, and the other medication, about half of them. So outcome of drug-induced liver injury. The U.S. Drug-Induced Liver Injury Network looked at this, and immunoallergic features were found, at least two of fever, rash, eosinophilia seen in 16%, most common with Bactrim, cefazolin, and Cipro. 10% died or needed liver transplant. High risk in these with chronic liver disease before DILI. 75% developed chronic DILI. Hepatocellular cases more likely to be fatal. Cholestatic or mixed more likely to be prolonged and result in chronic DILI. So DILI from herbal and dietary supplements. This is the DILIN data. 130 patients with DILI from herbal and dietary supplements. Most causes due to one of these categories: anabolic steroids, green tea, extract, and multiple nutritional supplements. And most of them are used for weight loss. Of the herbal and dietary supplements, 35% were bodybuilders and 65% were non-bodybuilders. Bodybuilders, DILI had high value of bilirubin with only mildly increased ALT. No patient died or required liver transplantation. Non-bodybuilders more likely to result in liver transplant than prescription drugs. So you can see there is a different type of drug injury. This is drug which induce steatosis, mainly drug-inducing steatosis like amiodarone, tamoxifen, methotrexate. There is drug which induce microvascular steatosis like valproic acid, ASA, and tetracycline. There is also drug which induce phospholipidosis like amiodarone and chloropromazine. There is also a drug can cause an autoimmune hepatitis. 90% of DILI were indistinguishable from autoimmune hepatitis, like nitrophenatoin, minocycline, and alpha-methyl-dopa. Most likely in females who are exposed for more than 3 months. Long-term immunosuppression usually not required in these patients. What about drug-induced in patients who are taking immune checkpoint inhibitors? So immune check inhibitors allow immune system to attack cancer cells, and drugs are usually associated with immune-related adverse effects. You can see here different type of immune check inhibitors. DILI immune check inhibitors, because hepatitis may occur anytime after initiation of therapy, median in 5 weeks. 1/3 of patients will have history of other organ immune-related adverse effect, and 1/3 of patients with severe hepatitis will have fever, and 1/3 will have rash. Autoantibodies are either negative or low levels or titers, IgG usually normal, and you can see here the histology pattern. Can you put it back? I'll finish. Just. There is also a DILI caused by anti-TNF, like infliximab, adalimumab, and 70% of patients has positive ANA. So those patients who are exposed to anti-TNF antagonists, none of the patients in the study, none of the patients require hospitalization, half treated with steroids, and all patients resolved and steroids were discontinued. 8 out of 11 patients were started on different anti-TNF agent without a problem. No significant liver injury can seen with Vido or istokinumab. You can see here how to treat patient who developed DILI due to, autoimmune hepatitis, or he was exposed to anti-TNF or checkpoints. Just 1 minute, I will finish. So this is the pathway how to treat this patient. If the LT more than 3 normal, continue the drug. More than 3 to 5% upper normal, you stop the drug, and more than 5, then you give steroid. And this is different type of drugs associated with DILI. You can see here ranging from acetaminophen to phenytoin, and how the pattern of ALT/AST are like. So in summary, abnormal liver test and DILI, known common presentation of uncommon causes of abnormal liver test, understand causes of increased liver stiffness, and be aware of presentation of drugs that are most common causes of DILI. Thank you.